would you like to begin with an introduction of yourself and what you do?
Yeah, my name is Alexei Danilov. I'm a professor in the Department of Hematology at City of Hope National Medical Center in Los Angeles, California. I also co-direct the Tony Stevenson Lymphoma Center at my institution, and I'm a director for early phase therapeutics as well. I'm a physician scientist who focuses on treating patients with B-cell malignancies, in particular CLL and mantle cell lymphoma.
Terrific. And again, thank you so much for your time today. We're excited to talk about your presentation at ASH this year. So to start off, could you give us a brief overview of your presentation regarding the EPCORE CLL trial?
Yeah, absolutely. So patients with double-refractory CLL, those who have progressed on BTK inhibitors and venetoclax, have limited therapeutic options, and results are suboptimal. So CAR T cells is one of the therapeutic options in this space, but they are associated with toxicities such as CRS, neurotoxicity, and frequent rates of infections. So certainly new treatments are needed. Epcoritamab is a CD3, CD20 bispecific antibody, which has been approved in treatment of follicular lymphoma and diffuse large B-cell lymphoma, which progressed at least after prior 2 lines of therapy. And EPCORE CLL-1 is a phase 1/2 study, which was designed to include expansion and optimization cohorts, and 40 patients were enrolled on both cohorts. Patients had relapsed refractory CLL. They had received at least 2 prior lines of therapy, and they had not received prior allogeneic stem cell transplant. In the expansion cohort, epcoritamab was given at 2 step-up doses before administering the first full dose of 48 milligrams subcutaneously. 23 patients were enrolled in that cohort, and in the optimization cohort, there were 3 step-up doses. The reason to do that was to mitigate some of the risks of cytokine release syndrome, or CRS. Additional measures to mitigate CRS were inclusion of dexamethasone prophylaxis, as well as prescribed adequate hydration. Overall, this trial enrolled very hard to treat patient population. They received median 4 prior lines of therapy. Majority were refractory to BTK inhibitors and also venetoclax, and 2/3 of patients harbored high-risk genetic mutations, specifically TP53 abnormalities. So the treatment was well tolerated. No patients discontinued for CRS. There were 5 patients who discontinued for adverse events in the expansion cohort, but adverse events were predictable, such as anemia, thrombocytopenia, neutropenia, fatigue, nausea. So those were the common adverse events. CRS occurred in the majority of patients in the expansion cohort. However, what we also have shown is that optimization cohort resulted in reduced frequency of CRS, and more importantly, the majority of CRS cases were grade 1. There were no grade 3 CRS in optimization cohort, and there were no cases of neurotoxicity in optimization cohort. In that cohort as well, use of tocilizumab was less frequent. So the optimization cohort, optimized cohort, resulted in significantly lower toxicities in terms of CRS and neurotoxicity in our patients. And as predicted, CRS occurred after the first full dose of epcoritamab in the majority of patients. The treatment was very effective, with overall response rate of 61% and complete response rate of 39%. And this response rate, this efficacy, was maintained across all cohorts of patients, including patients with p53 aberration, patients who were double exposed to both ibrutinib and venetoclax. So treatment worked regardless of genetic features. Progression-free survival median was about 13 months. So overall, this treatment resulted in high overall response rate in patients which were highly refractory, and it was well tolerated with lower frequency of high risk of high grade cytokine release syndrome in the optimized cohort.
Terrific. And with these positive results that you're seeing, how would you say epcoritamab is fulfilling the need for a novel, effective treatment in CLL?
Yeah, no, I think it's a state-of-the-art treatment approach which has not been tested so far in CLL outside of this clinical trial. I'm not aware of any data with other bispecific antibodies. Bispecific antibodies really made a substantial advances in treatment of non-Hodgkin lymphoma, follicular lymphoma, diffuse large B-cell lymphoma. Several agents are approved there. Glofitamab, mosunetuzumab, epcoritamab, like I mentioned before, but none have been approved in CLL. And, in this day of targeted therapies, when chemoimmunotherapy is no longer used in treatment of CLL, or at least shouldn't be used in treatment of CLL, we have BTK inhibitors, ibrutinib, acalabrutinib, zanubrutinib, and non-covalent BTK inhibitor pirtobrutinib, which is one class of agents. And we have BCL2 inhibitor venetoclax. And some patients do well on these treatments for many, many years, and some patients will never need other therapies. However, CLL is an incurable disease, and majority of patients will require new treatments after they progress on these targeted agents. That is where epcoritamab fills the niche. I believe also that in the future, epcoritamab should be moved into earlier lines of therapy of CLL because you can see that it can achieve deep responses in highly refractory CLL in patients who are pretreated with chemoimmunotherapy. And I think the benefit of moving epcoritamab into earlier lines of therapy is also such that we will be treating patients whose immune system is not still as compromised. CLL does result in immune system compromise in our patients. And moreover, using multiple therapies compromises it further. So when you administer epcoritamab to patients who have received 4, 6, 10 lines of therapy, including chemotherapy, um, it is it is somewhat theoretical, but fully expected that maybe we are not fully capitalizing on the T cell function in this patient. So moving epcoritamab into earlier lines of therapy in combination treatments is very important to achieve full benefit.
Right. And speaking of, moving it into earlier phases or how else you could use it, do you know if there's any current plans to further study epcoritamab in this treatment landscape maybe next year?
Yes, absolutely. So the study CLL-1, this study is ongoing, and it will continue to enroll patients, including in combination with BTK inhibitors and venetoclax. Some of these patients, by virtue of that combination, will be less heavily pretreated. Um, and also, we are discussing with Genmab about we have discussions about several projects where we will move epcoritamab hopefully into earlier lines of therapy. So this is under discussion. We do not have exact plans there yet, which I could share. But I'm very excited about those opportunities.
Definitely. And final question I'll ask you is if there was a patient that, listened to your presentation at ASH or read about it and how this research might affect their care, what would you tell them? What would you tell that patient?
Well, I will say, I mean, to all patients, I will say it is actually one thing. It is important to consider a second opinion when you are diagnosed with CLL, and in particular when a patient with CLL is about to start treatment. Secondly, I would say it is very important to look into clinical trials and what opportunities exist in your area or wherever you could potentially travel for clinical trials investigating novel approaches in CLL because these trials can actually be life-saving and can administer treatments such as epcoritamab, for example, which can result in long-lasting benefit in CLL. And for epcoritamab specifically, I think it is an exciting treatment approach. This trial is open and available, and particularly for patients who have progressed on BTK inhibitors such as ibrutinib and venetoclax. This is where this is the patient group which really needs to look into clinical trial opportunities. Because I do believe strongly that we have very safe, very effective regimens in clinical trials today, such as epcoritamab.
Well, thank you so much for your research and for explaining this for us today. And thank you for your time, Dr. Danilov. We appreciate it.
Thank you.